um, it's going to lead to a whole host of like individual questions. So if you guys have like really specific questions or even any general questions along the way, shoot them through, and then I'll kind of try to answer them as best as I can. So I'll just share my screen. Alrighty. So what I was told to present about tonight, sorry, can you guys see my screen through Shaker? Can you see that there, Catherine?
Yes, we can see that clearly. Thanks.
Just double checking.
Yeah, it's nice and clear.
Perfect. So what I was told to talk to you guys about tonight is an intro to orthodontics, intro to clear aligners specifically as well, and to kind of get you guys really excited about ortho just as much as I am. So, you know, if you guys do follow me on Instagram and stuff, you might see that I post a lot about maybe veneers or implants or just simple fillings and stuff like that. But to be honest, the bulk and the workhorse of my everyday work in my general practice is braces and ortho, like clear aligners. So on any given day, probably at least a third to half my day is actually all braces or Invisalign or Clear Correct or some sort of clear aligner system. And it's something that once you learn it, it opens up a whole realm to every other aspect of general dentistry, and honestly makes your general dentistry like so much better. So I'm going to try to talk to you guys tonight about kind of where my journey started, how I got there, why I chose orthodontics, and kind of like what it can bring to your clinical practice. And then, like I said, hopefully that kind of gives you a bit of a passion to possibly, once you leave uni, get out and do something with orthodontics. So like the ladies, you know, beautifully summed up, you guys have heard me speak before, hopefully. I am a graduate of Melbourne Uni, so I graduated a fair while away. This year is actually the 10th year of my clinical practice. So I graduated back in 2011. I own a couple of clinics down here in Victoria, one in Metro Melbourne and one in rural up in Heyfield. I have a few fellowships. The most important one, I guess, is the one in orthodontics. So as well as one in dentofacial aesthetics, actually, because I was actually recommended for that prestigious award through an orthodontist in Sydney called Derek Mahoney, who's a very prominent orthodontist up there. I'm also a co-founder of a group called the Young Dentist Hub, which runs educational events, webinars and seminars dedicated towards young dentists. And like the ladies beautifully said as well, I'm a speaker as well as an advocate for a few different companies too. What another general dentist and I, Dr. Anthony Mack, have come up with over the last year is a really exciting program too. It's called the DentalX ACE program. And it's essentially a year-long program for younger dentists or clinicians that want to really like take the next step to their whole general dental journey. So you don't want to specialize yet, but you just want to be like awesome or better at everything. So what we do is we cover rubber dams, treatment planning, camera setups, composites, crown and bridge, onlays, adhesive dentistry. We have Pascal Magnier teach a couple of the courses, so it's a really, really great course. It's been sold out for a couple of years in a row now, so I'm really excited to do that one, and that's based in Sydney. But I'm not going to talk any more about myself. Let's just jump to today. So the big question you guys want me to answer is, why orthodontics? Like, why do braces? What do clear aligners do? How do they work? All that sort of stuff. And traditionally, I tell you right now, and I hope no one from Melbourne's watching, at Melbourne University when I was going through, it felt like orthodontics was taught really, really badly. And whether or not it was or it wasn't, that was just the general perception from us in dental school. We had different orthodontists come and teach, and they weren't teaching like what we thought was like a strict subset or like, a subject. They just spoke about what they wanted to, what they were passionate about. They came 10, 15 minutes late and left us hanging by delivering half a lecture. And we kind of walked out thinking, oh my goodness, we're never going to do ortho again. We're never going to touch braces. And they put this massive fear into us. So I don't know if you guys want to comment in the chat box, but they put this massive fear to us that you should never touch clear aligners because clear aligners don't work. Clear aligners don't do anything at all. They are just for simple tipping of teeth. They don't move teeth at all, and they don't work. And that's what we kind of got taught. So I came out of dental school and I started work, and I was like, oh my goodness, I don't want to do ortho at all. I'm going to specialize in endodontics. I'm going to do root canals or something. And then I realized, like, throughout the years that my work, there was something lacking, right? Like I was lacking like this overall vision of what I wanted the smile to look like. I had this overall vision that I was lacking in terms of like how I wanted to restore a mouth. And I had no idea kind of how to go from simple class 2s, simple fillings, simple cleans, all the way to, you know, more comprehensive treatment. So then a few years into my, well, actually a couple of years into my clinical career, I said, look, there are 2 ways that you can go. And this is what all my early mentors said to me. They said, Sam, there are 2 ways that you can go from here. You either choose orthodontics or you go down the implant route. And I can safely say, you know, I now do both, but I can safely say that orthodontics has literally rounded off all my knowledge in all my general dentistry. Is made my composites better, it's made my implants better, it's made my crowns better, it's made my whole way of thinking in terms of how I do rehabs, alignment, and it's something that I am very, very happy to have done really, really early on, because not only has it made my clinical dentistry better, it's made my practice better as well, in the sense that orthodontics fills your books, right? So if you treat a child, or if you treat a patient that is underage and you win them over, or you do really good treatment on them, first of all, they become your patient for life. So they'll come every 6 months to do their checkups and cleans and all that other dental work. You open up all these avenues for other cosmetic dentistry, which we'll talk about later on. And then you win the family. So the whole family then goes, oh, you looked after little Jimmy really well. We're going to come in, get our dental treatment with you. I'm going to switch from that other dentist and come see you. Not for braces, not for Invisalign or Clear Correct, but I'll come see you just for your general work. So, you know, my books are full, and they got really full really early because I was doing braces. So if you're really interested in perhaps kind of, you know, getting really busy with your clinical practice very, very quickly, or if you guys are really starting out your own practice early on, I'd highly suggest going into orthodontics. So that's my little spiel about braces and Invisalign, and let's get talking about what they actually do. So this is obviously what we would expect with fixed braces, and I know you guys learn a lot of theory about fixed braces, but not much about like the hands-on component. This is a photo of essentially the orthodontic brackets on the teeth. So if you can see in each of the corners, there's obviously a little tie wing. And at the moment, this patient has a bit of orthodontic change just to kind of tighten up all the gaps there. So this is a traditional way of thinking how to straighten teeth. Like we were thinking, okay, this is how we're going to straighten teeth. We put braces on, we put them on for 2 years. We consider taking, you know, 4 teeth out, and they get lovely straight teeth. The game's really changed. I'm here to basically tell you guys that we're really leaning towards clear aligners in the whole orthodontic world now, and not just the GP world, but the actual modern orthodontist world. And this is going to be very contrary, or again, you guys can comment in the chat box as to what you guys are taught in uni, because when I was taught in uni, they were so anti-clear aligners. They were so anti-Invisalign, so anti-clear correct. They said, if you do anything more than a class 1 simple tipping case, if you try to expand the teeth, or if you try to torque teeth, so that's moving teeth kind of through the bone a little bit, then you're not going to get that at all. You're just going to get tipping. And, you know, I would highly disagree with that statement, because you can either choose to put braces on a patient that wants a really lovely aesthetic smile, or you can choose to put clear aligners on a patient and give them a really, really nice set of teeth with a really nice cosmetic result. So I don't know if my internet's lagging. I'm just trying to go to the next slide. Perfect. So this is the difference. You can either give them a big chunk of metal, wires everywhere, rubber everywhere, elastics everywhere, or you can give them this simple piece of plastic that they then wear to straighten their teeth. And there are numerous differences from clear aligners to fixed braces. And what you need to understand is a few things, okay? They both have their pros and cons. Nothing is the be all and end all. Nothing is like, you know, the bee's knees. Some things are just, you know, a little bit better, or, you know, some things are a bit worse. So the difference really is when we talk about clear aligners, they're completely removable. So the patient actually really needs to wear it themselves. The biggest emphasis with clear aligners is if the patient does not wear it at least 22 hours a day, teeth will not move. That's just the simple biology of things. If you don't make the patient or get the patient to have good compliance and they wear the aligners for 22 hours a day, they're not going to get good results with the treatment. On the upside though, it's very, very nice and clear. It's discreet. It's very aesthetic. So it's very good for those patients that come in and they want that whole aesthetic treatment. So they're here for veneers, or they're here for resin bonding, or they just want something that is very, very aesthetic. They're a little bit older perhaps, and they have full-time jobs. They don't want to walk around with, you know, what they call train tracks on their teeth all day long. So it's a very good option for them there. It's also really good in the fact that when we are planning for things like veneers, when we're planning for things like full mouth rehabs and implant placement, we can use that technology. We can use those scans. We can use that ClinCheck or that treatment setup that diagnoses how the teeth are going to move. And we can then determine precise tooth movements, because then when we want to plan that implant, when we want that veneer to be 8 millimeters wide, we can do that with clear aligners. Whereas with braces, what you need to do is you need to actually manually use springs, manually use chain and elastics to try to close spaces. And then sometimes you just don't get that kind of like comprehensive, precise movement. It's a very, what we call modern approach. So I guess it's like the in vogue, the fad sort of thing to do. It's the cool thing. You know, if you had little Jimmy go to school and he's the only one that's got clear aligners as opposed to everyone else that has braces, you kind of go, oh, look, you know, my parents couldn't pay for clear aligners, so, you know, I've got normal braces. So that's the kind of difference that you get, or the perception that you get in terms of the general population in regards to what clear aligners are all about. Clinically though, it kind of also means a little bit less time chairside. So once you kind of get a little bit busier, once you start filling your books up a little bit, you need to kind of think about how long a treatment's going to go versus how much you're going to get rewarded in terms of your time and your pay, especially if you guys are going to start going on commission. And I know, you know, life's not about money, but at some stage we need to talk about how to keep the lights on at the clinic and how to keep your books full and all that sort of stuff. But it also requires less of an emergency appointment. So you essentially don't get patients that come in for a broken bracket or a sharp wire or something digging into the cheek or an ulcer. You just almost have very, very precise, you know, you've got a 15-minute appointment or you've got a 10-minute appointment. You're going to do this, you're going to do that. And then everything kind of goes a little bit more according to plan, which generally means that you have to spend, or you don't have to spend as much time with the patient as you would normal braces. So that's good in the sense that if you're trying to kind of schedule your books, and I know obviously you guys aren't at that stage yet, but scheduling your books can sometimes be really hard. I was just talking to Thusheka before. She was like, oh, you know, I love the stuff that you're posting on Instagram at the moment. And I'm like, oh, look, we've been flat out, you know, this week alone, I've probably done over like 10 implants, 3 or 4 veneer, like porcelain veneer inserts. Every day we've got like a couple of crown preps, a couple of crown inserts and things like that. It's just that you don't have time to kind of post things on Instagram, and I don't have enough time to see my ortho patients. But then again, if I have clear aligner patients, I know that they're booked in for 10 minutes, they're booked in for 20 minutes. I can put them in between those 3-hour appointments. I can put them in between those 4-hour appointments, and I don't need them to wait, you know, till June to see me next. I can put them in wherever I need to put them in because I know their treatment's going to go really well and really predictably. It does limit how you move the teeth though. So the downside of clear aligners, I guess, is the fact that, yes, like essentially they're kind of correct when they teach you in uni that clear aligners don't move the teeth around that well or that much if you don't know how to use them. So if you rely on a piece of plastic, which is essentially what a clear aligner is, it's a piece of plastic. If you rely on that clear aligner plastic to move your tooth 8 mils, like close an extraction space or something there, and just do it willy-nilly and expect teeth to move exactly how the treatment's set up, so the ClinCheck or the prediction says it will, then you're not going to get that movement. All right, you need to use your brain still. You need to figure out how to make a tooth move properly with those clear aligners, and it's very different from with braces, because with braces you just put a wire on, you put a chain on, you put elastics on, you close the gap, done, right? Like it's very physical. You put a chain to close something. You get the patients to wear elastics to fix up a bite, all right? It's very, very easy to think of that black and white stuff. Clear aligners, you really need to use your brain. You need to figure out, okay, if I'm going to close an extraction space and clear aligner is only going to grab the tooth on the crown, the coronal aspect with plastic, then how am I going to close that extraction space without just tipping the teeth into the extraction space? How am I going to close it so that the roots then move with the rest of the teeth? I hope that makes sense, right? So you need to think of your brain a little bit better in terms of how to move those teeth, because they move very differently with clear aligners as opposed to braces. So the other kind of thing about that too is with clear aligners alone, you need to make sure that you're using different types of auxiliaries. So auxiliaries mean that you're going to be using a lot of buttons, attachments, cuts in your trays, rubber bands, elastics, or whatever they call them, chain, even partial braces before you put aligners on, braces after you put aligners on. You need to use TADs, which are kind of like these little mini implants that you screw into your jaw or your gum. You need to use things that help with those clear aligners. So that's the difference. Like clear aligners most of the time can't be used on their own. They have to be used with something else as well. So if you have like a really rotated tooth, clear aligners, the piece of plastic is not going to grab that tooth and twist it 90 degrees. It's just not going to happen. So you need to possibly use a couple of orthodontic chains or some buttons and some elastic to kind of twist that tooth around a little bit. So then it gets to a stage where the plastic can actually grab the tooth and then push it that little bit further to straighten it up properly. So a lot of differences between clear aligners and fixed braces. What I want to really kind of, I don't know, blow your minds with a little bit, I guess, is this graphic here. So this is a independent study that was published in the Journal of Clinical Orthodontics, the JCO, a few years back now. It's a very, very vital study in terms of how clear aligners work. And if you guys know what clear aligners look like, then you know that clear aligners usually have this little button on them. So some teeth would have a big button or a small button or a square button or rectangle button, but whatever they have on their tooth, it's either called a button, attachment, or engager. And what they found is that these clear aligners, it really depends not on whether or not there's a button or whether or not there's an engager on the tooth as to how well it's going to move the tooth. But the most important thing in regards to clear aligners is where the clear aligner is actually cut. So this is what we call a trim line. So when I talk about a trim line, so when I talk about Invisalign, if you see the edge of the trays, you'll see that there's a scallop there. So it's, it looks like a bleaching tray, essentially. So that would be what we call a scalloped trim line. You compare that to something like Clear Correct, which has what we call a flat trim line. So it's actually cut above the gingival zenith, usually between kind of like the gingival zenith to the 2 mils above the gingival zenith, but straight. And what they found is that although some people argue that buttons and attachments are really important to help you twist and turn teeth and grab teeth better, to move teeth better, the number one thing that actually helps you retain to teeth or grab teeth or hold teeth or move teeth is actually how a clear aligner tray is cut. All right. And the best way I can put it is, if you guys do bleaching trays in uni, when you kind of take the tray off the model and then you start trimming it, you do a very quick straight cut. Yeah. When you do a really straight cut, even though the material is very floppy and flimsy, you give it a feel. When you give it like a push, it actually feels rather firm, right? But then once you actually start doing the scallop margin and trimming it along the gingival margin of all those teeth, then feel the whitening tray. Feel it especially along that scallop region where the buccal aspect is. Feel how flimsy that is. And that's the same thing with clear aligners. If you have a scallop trim line, what they found is that it just wasn't retaining as well to the actual teeth themselves. And then what that means clinically for me really is the fact that it means that I can't move teeth better. I can't push teeth better. I can't pull teeth better. I can't extrude teeth. I can't move a tooth left or right, or you know what I mean. So it's really important to me about the trim line if I'm going to do like a really important clear aligner case. And that's one of the reasons why I use a brand called Clear Correct predominantly over Invisalign or Angel Line or the 20 other freaking brands out there now. There's literally so many of them out there. But this is a really important study to actually understand when you graduate and start using clear aligners. It's more about the cut, not the actual buttons themselves. So what does a clear aligner look like? Coming back to what I was telling you about before. So for people that haven't ever seen what a clear aligner or Invisalign tray looks like, this is what a ClearCorrect tray looks like. So you can see here, you've got what we call a straight trim line. So that's the edge of how everything's cut. You can also see there as well that there are numerous little things in the middle of the actual tray itself. So they're actually what we call buttons, attachments, or engages. And they're little composite blobs that we glue to the teeth. And the traditional way of thinking about buttons attachments was that this is what we use to push teeth, like door handles. So you kind of use them like doorknobs. And if I wanted to twist the 1, 2 to 2, 2, I place that little doorknob there. So then I can kind of push the tooth left or right to twist it around, all right? And that was traditional way of thinking. But again, coming back to that previous study, sometimes teeth are moved much better by just using no buttons or attachments at all. You can notice too that once the patient wears them, when they talk and when you smile to them, it looks way better than braces, way better than anything else. It's just a really, really nice, easy thing to wear. But again, you need to make the patient aware that they need to work 22 hours a day. And because of this, if you don't have a patient that has good compliance, if you are really worried that the patient doesn't brush their teeth, they're not going to basically wear the trays properly at all, don't give them clear aligners at all. Okay, that's my biggest take-home message for you guys right now. If you guys start clear aligners, then find a really good patient that has really good compliance. Make sure that they're good brushes, make sure that they're going to wear everything for the 22 hours a day, and then run with it. So this is a bit of food for thought, all right? So this is going to contradict almost everything that you guys have heard in your traditional orthodontic training at uni. Most of us dentists these days and a lot of orthodontists these days actually use or try to use clear aligners for, if not the majority, then all of orthodontic cases. All right, and this is a bit of a mind blow for me when I first heard this. There are some very, very prominent orthodontists just in Australia alone, right? Like Australia, that use clear aligners for every single one of their orthodontic cases. And this does not just mean simple extraction cases or alignment cases. This means orthognathic surgery cases. So you are literally doing Bimax surgery. You are doing class 2, mandibular advancement surgery. You're doing class 3 retrusion surgery. You are using bone plates. You're using TADs. You're using screws. You are using everything, right? A lot of orthodontists out there in the world are now doing all these cases with clear aligners, not braces, clear aligners. And this is the world that we're getting to now. So this is what you guys need to understand. You are the new generation. I'm becoming like an old hat now, right? Like I'm starting to get gray hairs everywhere. It's not fun. You need to understand that when you kind of come out, digital technology, digital dentistry is coming a huge way now in the last 5 years. So get on board with digital dentistry. And second of all, get on board with clear aligners. But when you do a clear aligner course, you need to understand that if you just do a simple clear aligner course, that is not going to be enough. You are not going to have enough to do every single treatment under the sun. So I would highly suggest you guys do a full orthodontic course. I have no specifics as to which brand or company or provider you want to go with, but I've done a 2-year course through POS. I've also done a few modules with Derek Mahoney up in Sydney with the EODO program. But it's totally up to you to start your ortho journey in terms of doing a full comprehensive course as opposed to just doing a 1 or 2 day orthodontic course through a clear aligner company. If you come along to the ClearCorrect courses that I teach, we try to teach, or I try to teach as much as I can through the 1-day course, but there's only so much you can teach. As you guys know from uni, from your orthodontic courses, there's only so much you can teach about clear aligners in an hour or a day or a week or a semester. So coming back to clear aligner treatments are more than just simple alignment. It's more than tipping of teeth. Okay, every single orthodontic tooth movement is possible. So if you just saw the graphic that I showed you, you can close open bites. You can translate teeth. So translation means moving a tooth bodily, so moving the whole tooth and the root from an A point to a B point. All right. You can tip teeth, you can rotate teeth, you can torque teeth, you can retrude teeth, you can do whatever you want. All right. You just need to know how to do it with the clear aligners. And if you don't know how to do it with clear aligners and auxiliaries, you need to know that there are limitations to the amount of tooth movement that you can do with just clear aligners alone. So that's where the auxiliaries come in. That's where the fact that you just need to use screws, elastics, chain, all that sort of stuff. And that's also why a comprehensive orthodontic course is going to be really, really worthwhile for you guys to get on board. So all my associates get told that the sooner you can, the better. Start an ortho course straight away. I know you guys are going through Griffith, and I know you have to pay a little bit of fees for your dental courses, but it's a worthwhile investment spending that $20,000 to $25,000 to do that ortho course, because that is going to set you up for life. That's literally going to set you up for your whole career, and you will not regret it whatsoever. So what can we do with clear aligners? Like I said, you can do class 2, class 3 occlusions with elastics, so the same as braces. It's not just limited to class 1 canines and class 1 molars. You can treat normal class 2 and class 3 like you would with normal braces. You can do extraction cases. You can do what we call molar distalization cases, where you're trying to move a molar all the way backwards, like even 8 mils if you need to. You can do skeletal anchorage cases. You can do orthodontic surgery cases, right? Like there are so many things you can do with clear aligners. It's not funny. Like I don't want you guys to believe the older orthodontists, and again, I hope no one goes and blabs to me, to them about me. But you will find so many orthodontists and general dentists like myself will now advocate for the use of clear aligners in almost every single ortho case, provided you find the patient with the right compliance, and provided that you know what you're going to do in terms of if something goes wrong, and how to use things like auxiliaries for those clear aligners. Okay. The other thing it does though as well is once you kind of get clear aligners and ortho into your belt, it allows you to do so much more. So it makes my cosmetic dentistry better. It makes my composite dentistry better. It makes my veneers better, my crowns better. I can align teeth to the exact position that I want them to. And it means that I can get better function out of those teeth. So then the teeth don't wear as much, my veneers don't chip, my composites don't chip, things don't break. But it also means I can get a much more aesthetic result too. So I can make sure that that peg lateral that I need to build up is exactly going to be 6 mils in width by the end. I can make sure that my front teeth are all going to have the right occlusal cant, right? There's so much more that it opens up. And I know that some people actually do clear aligners now to not make a profit at all. They don't even try to make money from it. They sell, or they provide clear aligners for a very low fee, because they know afterwards people are going to get veneers. They know people are going to get resin bonding. They know people are going to get whitening, and they know people are going to get all this other treatment as well. So it just opens up this whole realm of dentistry that you guys never thought existed, or you used to do, and you used to think, yeah, my veneers look good, but I can't pinpoint what's 100% wrong there. You start looking at things differently. You start looking at root torque, and you start looking at the crown position. You start looking at retroclination, proclination, all that sort of stuff that right now I guarantee you guys aren't looking at. Once you start doing ortho properly, you then go, wow, like my old veneers look shit. I'm happy to say before I did ortho, my old veneers, my old composites probably look like shit, right? And it's just something that you need to go through orthodontics to then learn how teeth should look, if that makes sense. Just looking at the questions at the moment here. We said, someone has said, Uni Melbourne's not really anti-clear aligners, but now the ortho is still taught bad. Yeah, look, 10 years, I'm not really sure how much has changed there. Carl says, when you say full ortho course, what sort of commitment are you talking about? So essentially, if you go through a POS or EODO course, or a IAAD, or even an Ortho Ed program with Jeff Hall, it's essentially 2 to 3 years, and you would go every 1 to 2 months for a period of maybe 3 to 4 days at a time. So generally, they like to space it out from Thursday to Monday, so then you don't have too much time off work. And then with the POS program, it was over the 2 years. We had 12 seminars in total. So it meant that we were there every second month for a period of 4 days at a time, from Thursday to Monday. Very similar with EODO. They do usually 4 days over the same days, like Thursday to Monday. And again, it's a 3-year program now. And you do it essentially kind of like every month, every couple of months or so. Jerry, if we were to do a full ortho course, would you recommend doing it straight out of uni? Yeah, look, if you guys have the money, it would be one of the first courses I do. So this is my recommendation for people when they first come out of uni. Do a great composite course. All right. Don't just do a course that some company recommends, or you get it for free, or you get it for cheap. Go and do a proper composite course. All right. Learn how to do a really good posterior and anterior composite. That's my first recommendation. Second recommendation is learn how to do endo really well. So do a really good endo course, but an endo course that also teaches you how to diagnose pain. Because even my associates right now, they misdiagnose pain all the time. And you don't build your books, you don't build your name, you don't build your practice just with cosmetic work and stuff. You build your practice because patients know that you're the dentist that didn't cause them pain, but more importantly, you treated their pain, right? Like if they came in with a toothache, they want to walk out without the toothache. And then lastly, the last one would be clear aligners and ortho. So that would be how I'd fill out my initial learning. I would also love, people, and especially my associates, to go and learn how to do a proper crown, a proper onlay course, and not just learn the techniques that were taught in uni. Unfortunately, when I was going through uni as well, zirconia was a taboo word. It was kind of like Voldemort. You were not allowed to speak of zirconia. You were not allowed to place Emaxes on posterior teeth. You were not allowed to do onlays with minimal retention. Adhesion dentistry, so biomimetic adhesive onlays. No, you had to basically do a chamfer margin for an onlay. Right? That doesn't even make sense to me, right? It didn't even make sense to me back then. It doesn't make sense to me now. So go and do a...
Can I just butt in and say we have prime and bond active one-step bonding agents at Griffith Uni, so I don't think we're getting very far with that.
Yeah, look, unfortunately, Andrea and Dental Barcelona have kind of, I think, infiltrated Griffith Uni quite a bit through Sheka. I have connections with Kerr. So if you guys want me to try to get Pascal Magnier to talk to you guys, if you guys want to get Optibond FL into your clinics, Optibond FL, and this talk is not sponsored, right? So I'm happy. I'm going to talk about everything I want tonight, right? Optibond FL is the gold standard in bonding. So if you guys don't get on it when you come out of uni for your onlays, your crowns, your what we call your immediate dentine sealing, and I know tonight is not that discussion, but if you don't get on that, then you're miles behind in terms of adhesive dentistry. So if you guys want me, so through Sheka, if you've got the contact details and give me who's in charge of the educational program on the student side of things, or who's part of the student committee, I can perhaps get Kerr to kind of like at least give you guys like some samples of Optibond FL. Maybe you can try it in clinics or pre-sim or preclinical, sorry, and give that a go, because
yeah,
Optibond FL got shown the ball last year. Wow. Okay.
Yeah, no, we did use it in our sim labs, but I don't know if they still have it in second year sim labs anymore. I've got a feeling they've changed it all in the clinics anyway, so I'm assuming they've changed it throughout the whole clinic. And if it's still in the sim labs, it's probably just like the expired ones that they're using there. So unfortunately, I think the reasoning when we did ask.
Okay. All right. Okay. Well, look, I've said my piece, so I'll move on.
I definitely will have a long chat about figuring out how to get this into our clinic. So that'd be really great. And also, if we could have Pascal Magnier, that would be absolutely fantastic. Yeah. So I'll chat to you about that after this lecture, Sam.
That latter one is probably a little bit more of a stretch, but like Optibond FL.
Yeah, no, definitely.
So I mean, the Prime and Bond Active has a new technology to it. It's got a different smell. They claim it's got better wettability, but I've yet to really see that long term. look, it's a great bonding system. Is it the gold standard? Is it what you would be using for adhesive onlays? I would be very, very reluctant to want to use that for a minimal prep or minimal retention onlay right now, when I want something that I know is going to work for like 10, 20 years, proven results. And, you know, in 20 years time, I might say differently, you know, but at the moment, I'm happy to stay with what some of these fathers of biomimetic dentistry say. Pascal, you know, if he claims Optimon FL works, I'm going to use what he says, essentially. All right, getting back to clear aligners. Sorry, sidetracked a little bit. How do they actually work? All right, so people always think clear aligners are things that will tug your teeth and pull your teeth and move your teeth like braces do. They work completely differently from fixed braces. So what you need to understand, and this is one of the main things I want you guys to take away from tonight. Clear aligners progressively push your teeth into the shape of each aligner tray. And they do this safely in a way that, depending on the company that you use, it will essentially push your teeth perhaps 0.3 of a millimeter or 0.15 of a millimeter with each tray that they wear. So each tray that they wear is what we call a different step. So they'll start from step 1, they'll go to step 2, step 3, step 4. Depending on what sort of movement you want to do, depending on how young or old the patient is, would then depend on whether or not they're wearing it for 1, 2, or 3 weeks at a time before they move on to the next tray. All right. The pushing thing has really, really big implications. And again, if you come to one of the courses that I teach, we'll talk to you about why. But it has really big implications as to how you're going to move those teeth effectively and efficiently. You cannot allow the treatment setup or the prediction on the screen to dictate whether or not you think a treatment is going to work or not. Because at the end of the day, it's just a cartoon. It is just going to say, you know what, Trisheka, we can move your teeth from here to here by twisting the teeth 0.5 of a millimeters, right? And yeah, in theory, if everything were to work perfectly, that tooth may move that 0.5 of a millimeters. But if you haven't designed the treatment well, if you haven't designed the movements well, if it's a particular tooth that won't rotate that well, right, you are not going to get a really efficient or effective treatment, and you're going to think that the clear aligner tray is shit. All right, you're going to think, sorry, I keep saying the word shit tonight. I'm sorry, but it's been a long week. You're going to think that clear aligner tray is not working effectively, and that brand or whatever is not working properly for you. All right, and you're going to go on blaming the product. And I'm here to tell you guys, unfortunately, to the 75, 80 people that are here in this room right now, it is not the clear aligner that didn't work for you, because almost every clear aligner is exactly the same, except for the cost that they charge you for the lab fee, and the cut of the trim line. Essentially, otherwise they're all the same. They're all a piece of plastic. All right. If you don't respect that plastic, if you don't respect how to use it, and you don't respect the movements that you can even do with the clear aligner trays, then you are never going to get a good treatment result. You are never going to get good at clear aligners, and you will always blame the product, not the person. And sorry, that's just me going off on a mini rant, maybe because today's my Friday, I'm not sure, but just beware, okay? Like Invisalign, ClearCorrect, Angel Line, Smile Styler, all those brands are the same. If you don't understand how clear aligners work and that the fact that they need to push your teeth, then you won't get a good result. All right? One example of that is just, I know you guys probably got lots of questions about what I'm talking about. Let's say you're trying to move a lower canine. All right. So a lower canine, if you think of your tooth morphology, it has a really conical root system. It's 3 centimeters in length, all right? And the crown itself is very conical. Even if we put a little button on the front of the tooth, even if we put a button on the back of the tooth, so the buccal and lingual, by the way, studies have shown that lingual buttons don't work. If you put a button on those teeth and expect a piece of plastic to twist and grab that round tooth with the round cross section, the 3 centimeters or 2 centimeters of that root structure, and twist it around 30 degrees, 40 degrees, 50 degrees, you're joking. All right. What you need to understand that is the plastic won't grab the tooth and twist it. The plastic is actually going to push the tooth on either side. So let's say I had a lower canine, it was rotated distally. So the whole crown was kind of like leaning towards the distal or twisted towards the distal. I can't expect a plastic tray to just twist that tooth back around. if you don't program the treatment well, what will happen is that the plastic will try to push the tooth on the distolingual aspect and push the tooth on the mesiobuccal aspect with the plastic, and just progressively try to twist that tooth back around. But again, if you understand tooth morphology, the tooth is round. It's not going to work very well for a tray to do that. And the tray can't actually even grab the tooth or have a lot of surface area to grab that tooth effectively as well. So the better way to actually move that lower canine, the one that's very tricky to move with clear aligners, is you do what we call a round tripping motion. So that's essentially where you would try to procline, so push out all your teeth in general, right, especially the anterior, until you actually get physical space in between the teeth. So you're proclining and getting space of those teeth. So I hope people can see my hand gestures. And then what you're going to do afterwards is, as you're pushing those teeth forward, you're actually going to get the clear aligner tray to actually start to derotate that lower canine. So the tooth will then be pushed in that distolingual aspect lingually as it's getting splayed out. And then when you actually have gaps in between the teeth, it then means that the plastic can actually go in between the teeth and fit around better. So it then has more surface area to grab or push the tooth. And then you would then retrocline to bring those teeth back. And then whilst you're retroclining those teeth, then you would be applying some pushing force on that mesiobuccal aspect to derotate that tooth. So yes, it takes a little bit longer to get that rotation, but it is much more effective, efficient, and more predictable to derotate that canine by understanding that you're going to push the tooth out, but at the same time derotate the tooth. And then when you push the tooth back, you're going to derotate that tooth again. So that's a little tip that I've got for you that I always teach during my ClearCorrect intro courses.
Sam, can I just ask, when you're doing derotation, does that extend the time frame of the clear aligners a lot more than what it would have been?
It usually extends it maybe about 5 or 6 steps, so maybe like another 10, 12 weeks. But you have to understand you're derotating almost all the teeth at the same time, essentially, almost. So, you know, would you rather a treatment go for 1.5 years, or would you rather a treatment that's supposed to go for 1 year, but things don't move properly, and then you have to then order new trays? And that's what we call a revision. You have to understand ClearCorrect and Invisalign, they're both made in the States. They take a month to get sent out. So even if you took scans, digital scans, and you got a ClinCheck ready, it generally takes 1 to 2 weeks to get to a stage where you're happy with that ClinCheck. And then it takes another month to send things out. So during that time, the patient's wearing their old trays for 5, 6 weeks and nothing's happening. And you'd have to do that maybe once or twice if things aren't moving predictably. So you would end up having a treatment that goes for longer, even though the initial setup, the initial ClinCheck said that it would be quicker. Does that make sense?
Yeah, makes sense. Thank you.
So yeah, it takes a bit longer in general, but it usually saves you a lot of heartache and misery and stress and revisions and extra molds. When you guys start out, you're going to be taking PVS. And what you need to understand with clear aligners is when you start out without a scanner, you're essentially taking a crown and bridge prep of 14 teeth. And if you have one bubble, if you have one tear, if you have one void on one of those 14 teeth, you have to take that impression all over again. You can't just repair it, or you can't just add PVS to one section. So imagine like how hard it is for you guys to do a good crown impression right now. Imagine what that's like taking 14 teeth and getting it done properly. So that's what, it's just one of those things where, you know, the revisions are a heartache as well, because you need to book that patient in, take new photos, take new molds, take new scans, and then it just takes forever. Like chairside, you're there for like half an hour just taking molds, right? All right, so case selection. So when you first come out and do clear aligners, what do you start off with? So the best ones to start off with are what we call ortho relapse cases. So the patients that have actually gone through ortho before and they have like a little bit of movement that they're not happy about because they didn't wear the retainers. I'm a really great case to start off with. So I'm class 1, but my lower teeth have moved again. I never wore my retainers after the first year because my older style orthodontist just told me to stop straight away. And now I've got relapse. So that's a really great case to get started with. Mild crowding, mild spacing, mild rotations are always good to start off with. Spacing is one of those ones where it's one of the easiest cases that you're ever going to do. So just like I said before with that whole round tripping thing, it means that the plastic can grab the tray or the teeth a lot better because there's more surface area on those teeth. So when you have spacing, super easy case to do with clear aligners. It doesn't matter what brand you use, it's going to work, right? You probably don't need any revisions with that whatsoever. Make sure you don't treat any deep bite or open bites because clear aligners alone are very, very bad at treating deep or open bites because they're very, very bad at actually purposely extruding or intruding teeth. Okay, so I'll just leave it at that. If you have anterior teeth to be corrected, so if you have like, let's say 1-3 to 2-3 crowding and the patient just wants to fix that up, they don't want to fix up their molar correction, they don't want to fix up their bite, then it's a really good option there. Non-extraction, just because for now you probably don't realize what sort of movements you need to do to close an extraction case. And again, I keep saying this, you want that good, regular tender, but compliant patient, all right? What you don't want to start off with is rotations of canines and lower premolars for the very simple reason that I told you before with that lower canine. They all have a very round cross-section as well as coronal tooth structure, so very, very hard to rotate them. Canines that are high, so people that have those buckley high canines don't want to start off there at all. People that have short clinical crown heights, because at the end of the day, that's an issue for the tray to grab the teeth. So if you have a short clinical crown height, what is that plastic tray going to push? What is that plastic tray going to grab a hold of? Don't start off with anyone that has multiple missing teeth, bridges, implants. Crowns are fine to start off with, but just not other things like that. And people that obviously have poor compliance, poor oral hygiene, people that clench and grind their teeth. And the worst ones, in my personal opinion, when you're starting off and you just want to get a really good treatment done properly, patients that are calling around asking for prices, okay? That is not the patient that you want to start off with. You want the patient that has always been with the practice. You want the patient that has come back and seen you heaps of times for fillings and they come in on time every single time and they just trust you, okay? So what are the cases to get started off with? So this is a patient that came in to see me and she had previous ortho. Her older orthodontist put a wire from 3-3 to 4-3. And you can see here that there's a bit of mild relapse. We took photos and coming back to what I was saying before, if you guys haven't started already, take lots of photos. So in your clinical practice, when you first come out, one of the first things I need you to buy, as well as enroll courses, is a good clinical camera. All right. So I've put in the chat box a webinar that I've done of camera setups and what to buy, what settings to do on Facebook. You can go watch that if you like. It's a quick 30-40 minute webinar, but that's the first thing you need to buy because this patient came in and she said to me that her teeth were straight. She didn't need anything done and she just wanted her teeth checked and clean. We took photos like these ones and I said to her, you know, Lucy, have you realized that your bottom teeth have kind of gone a bit crooked again? And then she had a look at the photo and then I pointed out the crowding and she goes, wow, I didn't realize that they were crowded again. I thought like I wore my wire, so everything was okay. And we ended up doing clear aligners on the top and bottom, right? So a lot of the photography is then going to educate the patient and help you communicate with the patient to get your point across, because I could have easily said, oh, you've got a little bit of crowding again, but Lucy may not have believed me because even if I gave her a mirror, in real life, like subjectively, she's looking at the mirror with her eyes, with her own eyes, and she's seeing the fact that there's nothing wrong. Like her teeth are perfect in her eyes. Her parents have spent $7,000-8,000 in braces, and so she thinks that her teeth are straight. But you take photos and you show her objectively what everything looks like, and then she goes, wow, okay, let's do something. I want to do something. Let's go ahead. All right. Similarly, these are some really easy cases to get started off with, spacing cases. So you can see here, there's midline diastemas, there's a little bit of spacing upper and lower for both of these cases. Both these cases only take a few months. A few months, you're done, all right? And that's really hard to believe because most people believe that braces go for 1 to 2 years. These cases were done after a couple of months. What about these ones, right? Mild crowding, mild spacing. This one on the left, the one with the massive diastema, I used to make fun of her because, you know, or mum used to make fun of her, sorry, I kind of like laughed along, I guess. we used to say that we could park a truck through there, or we could fit a $2 coin in there, right? This was a game changer for my clinical practice because I posted this before and after case, and then patients started getting like just coming in. People think that it's really hard to close these diastemas, where in actual fact it's super easy. Like this case, to fix everything, including the deep bite that she had, only took like 7-8 months, right? Like it was super easy. Similarly, on the right-hand side, that mold crowding case, she actually has a missing lower incisor. That just took like, I think 3 months. And then we ended up doing resin bonding and did an upper left bridge on her after that. So you can see kind of how the work then starts to flow on for you after that. Mold crowding cases, again, these are cases that walk through your door each and every day. All right. So the patient on the right is actually a voice contestant. She was a voice finalist. She walked through my door. We fixed up her teeth in a matter of about 8-9 months, and she was done. The one on the left would only take you maybe 4 or 5 months to fix up, including the deep bite that they had, and then you're done. All right. So these are really easy cases to get started off with. Oh, my associate's watching this webinar right now. She says, I took so many photos today. So there you go. There's a testament from my associate to you guys. I harp on to every single associate that I have that you need to get in there, take photos, and show patients what they're missing out on. All right. Mold crowding cases. This is another couple of cases. You see these 1-1, 2-1 overlaps all the time. All right. And again, this is a little bit of a light bulb moment, and I'm not sure if you guys are ready to hear this, but a lot of the crowding that happens anteriorly is because of crowding posteriorly. So if you have a look at both these smiles, you can actually see that the posterior teeth are actually collapsed lingually now. So the arch form is actually more of a V shape, and they're much narrower than what they should be. All right. So ideally, to fix this up, you don't want to start doing treatment like Invisalign Go, all right? And sorry to people that are pro Invisalign here, and if there's even any Invisalign reps or people that are going to go start telling the Invisalign reps tomorrow, Invisalign Go is a product that only allows you to align 5 to 5. And yes, the lab fee is a bit cheaper, right? But there is a reason why we don't want to align 5 to 5 in orthodontics a lot of the time. It's because you then need to do what we call a lot of stripping, so IPR in between the teeth, where you're sanding healthy enamel away just to decrowd those teeth, to get space there. Wouldn't it be better to actually do full clear aligner treatment? So align every single posterior tooth, regain that arch length, regain that arch space, and align those teeth with less IPR? Wouldn't that be healthier for the patient? If it were you, wouldn't you want that in your own mouth, less IPR? So I put it to you, when you do those fast braces courses, those quick fix clear aligner courses, and unfortunately a name that I'm going to throw out there is Invisalign Go. When they say, oh yeah, you can do a case within 20 aligners, align 5 to 5, keep the patient happy, right? You could do both of these cases with Invisalign Go, all right? But will you be able to do it with very little IPR? No, you are definitely going to have to IPR a lot. And first of all, you're going to remove really healthy enamel. And secondly, you might change the contact points and contact areas of a lot of those teeth and unnecessarily reshape those teeth in a very unaesthetic way as well. Like if on the photo on the right, if I was to do IPR on those 1-1 and 2-1 teeth straight away, I would get such a really bad buccal contour on the 2-1 and a really bad flat lingual contour on the 1-1 palatal. It's just the way that it is. All right, so this is a big line that I told my associate that just commented, and a big thing that I always say in every single clear aligner course and orthodontic course that I teach: teeth are crooked because they want to be crooked. All right, so coming back to this diastema right here, there is a reason why an adult patient or non-growing patient has a gap in between their teeth. It is either a tooth size discrepancy, right? Or it is a prominent labial frenum tugging in between the teeth. All right. It is not because that gap is a family trait. It is not because of the fact that the teeth are there because they just got there, right? it is not the patient's fault that the gap formed. It is the fact that there's a midline diameter there that you then need to treat with the clear aligners, right? Similarly, if we kind of look at some other examples, so this is the same patient. This patient here, why are there gaps there? The main reason for the gap is not because the teeth are crooked. Yes, there's a bit of an occlusal cant and a deep bite there that we had to fix up. But the main reason for the spacing is because the shape of the teeth is incorrect. So the 1-2, the 1-1, the 2-1, and the 2-2 have what I like to call a tapered appearance, where the top of the tooth is actually wider than the bottom of the tooth. And that is giving you the appearance that the teeth actually have bigger gaps than they actually do. All right. So the reason why you had the gaps there in this case is because of the tooth size discrepancy. So let's talk about how you incorporate clear aligners into your everyday workflow, because at this stage, people kind of always go, okay, look, I want to get into ortho, I want to get into clear aligners. I just don't know how to do it. I've done a 1-day course. I've done a 2-day course. I've listened to a podcast. I've listened to some guru online and talk about intro to clear aligners. I've listened to Sam Koh's talk to GUDSA about clear aligners, and I'm going to start clear aligners right now. Okay. So the thing that you really need to understand is once you do a course, you really need to have really great mentors and really great support to hold your hand for the first few treatment plans that you do. Because the thing that you need to understand is that clear aligners need to be almost a valid treatment option in all of your treatment plans. It should almost be something that you ask almost every single patient. Are you happy with your smile? What would allow me to get your smile to a 10 out of 10? Do you mind having this wonky tooth? Is it ever a thought to you to actually straighten those bottom front teeth so that you can clean them better? It needs to be part of your discussion for almost every single patient that comes in for a checkup and clean. And it then becomes part of your actual multidisciplinary approach to what we call patient-centered care. And when I say patient-centered care, this is something that me and some of the younger guys out there now are really passionate about. We want to do really comprehensive but minimally invasive dentistry. So you want patients to look really good, but you want patients to look really good without having to cut a lot of their teeth away, strip a lot of their teeth away, and do unnecessary harm to their teeth. So you want to look after your patients really, really well. Okay. So how do you get there? First of all, go off and do a communication course. So once you've got all those clinical foundations under your belt, go do a course like Prime Speak or Momentum or something like that. Build up your communication skills so that you can actually talk to patients confidently, effectively, but also precisely and efficiently. All right. Market yourself, market your products, market your brand. Tell patients that you guys even do Invisalign. Tell patients that you do Clear Correct, right? Patients sometimes just do not know that you do it. Like I still have signs everywhere in my clinic. I used to pre-COVID. I still have some signs out now. I still have patients walking through the door. They see the signs everywhere. They see the pamphlets everywhere. They see my certificates on the wall, and they're still shocked to know that I do braces. They're still shocked to know that I do clear aligners, because some orthodontist, usually it's an orthodontist, has gotten it into their head that GPs should not be doing orthodontics. All right. And I'm here to say that GPs are one of the most important people to do orthodontics, but to do it well. All right. So the big disclaimer for me is do not come out and do clear aligners, a 1-day course or something, and go off and do an orthodontic case. Do not come out and do clear aligners and do a really complex case and get yourself in trouble. All right. Start off with what you know, or do a comprehensive ortho course so you have that knowledge under your belt, and then you can actually work through it. If something were to go wrong, you've got plan B, plan C, plan D, plan Z. All right. Find yourself a good mentor. Usually when I say this, I usually get a whole bunch of Instagram messages the following week. Yes, I'm happy for you guys to possibly ask me a question here or there, but I am quite busy these days. I have my own associates to worry about. If I don't get back to you, don't take it to heart. It's just because, obviously I've got to focus my time on my own associates, my own clinical workplace and what I'm doing. But find yourself a good mentor, whether or not it's at work, whether or not it's someone online, whether or not it's through a third party. There are some companies out there with people that will hold your hand when you do your first courses. So that might be a really good way to start. Read lots of textbooks. So I know you guys are using Profit at the moment, but go off and read clear aligner textbooks. So if you guys are pro Invisalign, right, go read Sandra Ty's textbook. It's an amazing textbook for people that want to learn how to do Invisalign. Okay. And like I keep saying, attend a more comprehensive ortho course to improve your bag of tricks. Because at the end of the day, even for me, sometimes a plastic tray just doesn't move the teeth to where I need them to move. All right. So you need to know how to get yourself out of the jam. How do I place elastics? How do I place chain? How do I place brackets there on those teeth if I can't move that tooth with the plastic tray? All right. You need to know how to do that if you're not doing simple cases when you first come out. This is a little side note. When you start doing orthodontics, when you start doing clear aligners, you instantly start getting busier, okay? It's a practice builder. It means that with every recall, you bring it up with patients. You do an orthodontic chart with every patient, right? You should always note down their occlusion. You should always note down how crowded they are and say it in layman's terms so then the patient can actually hear what you're saying to your nurse when you're charting, right? Take lots of photos. Once you straighten up a few cases, like that big Dyson case that I showed you, refer to it as much as possible. Show patients what you can expect with clear aligners. Take a photo of what clear aligners look inside the mouth. So the next time the patient goes, what do they look like? You show them a photo, okay? Better yet, treat your family, treat your friends. You can charge them less if you want. But then what you then do is then they're walking around telling their friends and family how well you're treating them, how good the clear aligners, how good they look, how easy they are to use, and they really start spreading the word of mouth for you. So that's what WOM means. And then you start getting busy. You start getting more patients. You start getting consults. Every time I have a chance to post up a clear aligner case or something clear aligners, I get a consult straight off Instagram, right? Like it's just that simple. Once you do a case really well, people come to you, right? Like I post up a veneer case on Instagram, I get a consult, right? That's just how it works. But the main thing is you also want to do really good quality treatment, and that will then give you good quantity of treatment after that, where not it's your whitening, where not it's your resin bonding, where not it's your crowns, your veneers, your implants. So this is coming to my very last point about today, because I did want to keep under 1.5 hours for heaps of questions and stuff. But I wanted to talk to you guys about how you incorporate clear aligners and orthodontics into your clinical practice. And a huge thing that I love doing, and I talk about a lot with my cases that I post, is a concept called align, bleach, and bond. And it's essentially 3 steps. You align teeth to put them in a better functional and aesthetic position. You then whiten teeth, and then you minimally bond to teeth without cutting teeth away. So that's where we're trying to get to these days. So it's a minimally invasive technique to then bond, or what we call resin bond or edge bond, or whatever you want to call it. We align teeth and bond to the teeth without having to cut them, okay? Without having to cut for veneers, without having to saw half their teeth away, without having to do heaps of IPR. We're basically trying to make the teeth without having to cut teeth away. If you guys want to see some examples, just head to my Instagram and then you'll be able to see a few examples there, right? But I'll show you something here as well. So we're trying to align the teeth, but we're working from the end goal to the start, if that makes sense. So we're aligning teeth with the final restorative goal in mind. So we want to get the right proportions, we want to get the right positions, and we want to get the right occlusion, okay? After we straighten the teeth, we will then whiten their teeth. So they can whiten their teeth with clear aligners. So even with the attachments and buttons in, give them whitening, all right? They can whiten their teeth with the buttons. The way whitening works is it'll actually go into the teeth around the composite buttons. It will whiten the teeth underneath the buttons, no dramas, okay? And that means that when you do the final restorations, you're not going to be masking the tooth color. You're just going to be adding to the tooth material that's lost. Finally, you do the resin edge bonding or the resin bonding, and a lot of us will call it edge bonding, resin bonding, composite bonding. A lot of patients know it as different things, so you can call it whatever you want. So here's a patient. I posted her up on Instagram probably like a couple of years ago now, or maybe a year and a half ago. A friend of a friend, again, referred to me because I did clear aligners. She had previous ortho, she had discolored teeth, and her main complaint was the fact that her jaw was off to one side. So the ortho left her well, sorry, I shouldn't say ortho, the orthodontic clinician left her in different classes on both sides. So you can see that her upper midline is a little bit to the right-hand side, but more so leaning, so tilting towards the right-hand side, and the lower midline is completely to the left. The lower midline is literally 3 millimeters to the left. Can you guys see that? So let me just get a laser pointer up. So that's her midline, okay, which is not that great. You can also see though that her teeth are different colors. It literally goes yellow, white, yellow, white, yellow, white. So not the greatest thing there. She had a root canal on the 2-1, so we had to do a bit of internal whitening, but we also wanted to even the color of all the teeth too. Sorry, my internet is very, very dodgy at the moment. So that's her teeth after the orthodontist finished it. Okay, so that's how they look on the bottom. So there's some moderate crowding there. You can see that the 3-3 and 4-3 are tipped in, or lingually retroclined, or lingually tipped. So these are some terms that you need to start learning with the orthodontic treatment. You can see the top teeth. So the 2-1's been root canal treated. There's some mild to moderate crowding there. You can actually see some occlusal wear here as well, which suggests that she actually has some parafunction as well. So you see that shiny surface there, that's some parafunctional habit right there, which she didn't know about. So again, I opened her up to getting a splint done, to get Botox done. So you see how her right masseter is a bit bigger? We now do Botox on her jaws. So not only have I done a line bleach bond, I've done her clear aligners with Clear Correct, I've done her masseters with Botox, and I've given her a splint. So that was her clin check, her treatment setup from the start. So I wanted to take it from here to here. And that was going to take roughly around about, I think 12 to 15 months from memory. Okay, don't quote me on that. I think it was about 12 to 15 months to get from there. So what we actually did is we actually did this using asymmetric IPR, because this is a really unique case where she came to me very persistent on not having to wear elastics again, not having extractions, and not having any other appliance whatsoever. So I offered her a lot of different options. I offered her surgery. I offered her extraction therapy, like unilateral extractions. I offered her molar distalization. She said no to everything, happy with IPR. All right. So we took her from this. This was the start. This was after the treatment, so you can see that she's got buttons on. I never guaranteed 100% improvement of the midlines at all, because that was way too much for the clear aligners to do without elastics and everything, but we guaranteed her at least 80%. So I said, if you're 1 to 2 mils off, would you be happy? And she was like, yeah, I'm totally happy with that. So not only have we fixed up the tooth angulations, the occlusal cant, we've also straightened everything up in terms of the midline, and then correct the deep bite a little bit as well. So this was the start. We then finished off her straightening. So you can actually see, can you see how the gingival zeniths have lined up? So what I mean by that is, can you see how the gingival contour of the 2-2 is much higher to the gingival contour of everything else? And then over time, we've then straightened everything up. So then all the gingival contours are much more even. Okay, so this is, again, it's allowing you not to have to do a laser gingivectomy, and it's allowing you not to be as destructive to the teeth and the gingival and the oral tissues as much as possible. Okay. She's then gone off and whitened her teeth. So she's gone and used polar whitening for about 3 to 4 weeks. I think she went really all out, did about 4 weeks of whitening. And now we want to replace that 1-2 composite, and we want to level out the incisal edges. So she didn't like the incisal translucency, and she didn't like the fact that her edges were all bumpy, but she didn't want to make her teeth shorter. So she didn't want to trim them down or anything. She wanted to build them up. So we did a freehand approach. So I've isolated, we etched, bonded, and then afterwards, that was the final result. All right, so we've leveled everything out. We've only added to the incisal edges. So these are not veneers. So the top 2/3 are still her teeth. Okay, so this is something that you need to understand. We are just adding to the teeth. So if one day she came back and said, I don't want this anymore, we just take it off. All right, it's not destructive. It's what I'd call semi-reversible, because at the end of the day, you will remove a bit of enamel, but it is very minimally invasive. So this is what her final result was. So if I go all the way back, this is what we started off with, right, on the left-hand side. And this is what we ended up with, just without cutting any teeth whatsoever. All right. All right. This is a case to show you that I do still do braces, and I do still a lot of braces, and braces still has a place. All right. So for those of you guys that don't trust plastics, and for those of you guys that don't, I guess, know how to necessarily close an extraction space with clear aligners, or know how to treat a class 2 case with clear aligners or growth case with clear aligners, this is one I did with fixed braces. Took 2.5 years. We timed it to growth. All right. So we actively chose to do it when he started his growth spurt. So you can see here, massive class 2, 8 millimeters class 2, right? If you leave these cases too late, right, you are going to have an unhappy patient, unhappy family, and a $20,000 surgery case, okay? You can win a whole family, and I've won the whole family now by doing this case during growth, but preventing them from ever needing surgery. All right, so this was a class 2 case, massive deep bite, 100% deep bite. Look at how retrognathic his mandible is. Can you see that? So when he smiles, it's like this, right? It is not a masculine look to have a class 2 jaw. We want to bring that jaw out so that it's in line with his aesthetic or orthodontic plane. So the nose, top lip, and chin all line up, which they don't do right now, okay? So that was him. You can see that his lower lip is strained. He's got what we call a really, really prominent sublabial fold because his chin is so far back, so his lip is pushed out. So it's almost looking like he's almost doing this all the time, right? You don't want that. So we put braces on. I think this must have been close to Australia Day or something. Who knows? But you went yellow and gold. Bless you, whoever just sneezed, Tusheka, Catherine. So it went from this, so narrow smile. Can you see the buccal corridors? I know some orthodontists out there say don't worry about buccal corridors because you can't expand teeth out that much. These buccal corridors you need to treat. You can only see 1.3 to 2.3 here. You need to treat this smile early, all right? So it went from there to there. And that was within 12 to 15 months. Sorry, no, 2 to 2.5 years, sorry. So that 100% deep bite, got it to this right here after about 2.5 years. All right. So there to there. And can you see his chin profile now? Like how much more of a man he looks. His gums are a mess. Like he didn't brush his teeth very well. And that's why he was a very poor candidate for Invisalign because did not brush his teeth very well at all. But see how much of a change that makes. Like if you just look after the patient, look after their teeth, look after the family, do things properly and treat them well. And if you guys want to write this down, I'm happy to write this down. You should be starting your orthodontic consults at around about 7 to 8 years old. That should be the first time that you see a kid for an ortho consult. Because unfortunately these days, females especially, you females tend to start your growth spurts, hit puberty really early now. Like some girls are having their first period and at 8 years old. And the general rule of thumb in ortho is once a girl gets their first period, they've already gone past their peak growth. So if you're going to do a case like this and they're past peak growth, it means that once they get to 8 years old, it's already too late. You should have already done the braces when they were 7 or 8, Same thing here as well for boys. Generally, when they're going through growth, their peak growth would start around about maybe 13 years old. And then as a general rule of thumb, girls are about 10 to 11. But you will have those exceptions where girls will start super early at 8 at 9. So you need to start doing the ortho consults every 6 months, basically from the age of 8. Boys will pretty much finish growing sometimes 18, 21. If they're class 3, sometimes you actually wait till they're 21 to do a surgery case. Girls tend to finish pretty early, so they'll finish growth around about 16 years old. So you kind of almost know when they're 14, 15 now, if you don't want growth, they're just class 1 already, you can treat them straight away. This is another case, a bit more of a complex case. I had to do a little bit of extra. You see the smile, it doesn't look too bad, but you can see some sutures in there. And this was a pretty fun case because this was a surgical retrieval of an impacted canine. So she had a impacted 1-3. We put some gold chain on the 1-3, pulled that down, did fixed ortho. So you can see the gold chain there, put some sutures in. But we worked from the finish to the start. So we looked at the peg laterals and we actually already designed the final restorations, which were going to be composites short term because she was a teenager. And we did them, we did the planning before we did the braces. So we straightened from this. Come on, internet. And this is the right-hand side view. So you can see that we had to find that canine. Left-hand side view, so that peg lateral needs to be proclined a little bit, derotated, and given what I call mesial root torque, just to kind of twist that a little bit better. That was the occlusal view post-surgery, so that's with all the sutures and everything and the gold chain attached. The lower, so not much crowding there, but a lower anterior crowding. That's her with the braces. Basically almost ready to have the braces off. So we had planned the gaps. We had planned where I wanted to position the 1-2 and 2-2. We then took the braces off. That's what she was post braces removal. So you can see the gums are all puffy. You see that everything's a bit dehydrated for the photos because I had her mouth open for quite a while. This was, by the way, after about 2.5 years of treatment. Canine retrieval can take a really long time to do. So we went from that to this in the one visit. So we did resin bonding, mimicked all the white spots that she had, and we did it all in the one visit. All right, so we had designed this right at the start, 2.5 years ago. It was all planned already. We just followed the plan, right? So that was the final outcome. That was the final smile, and that were her final restorations. All right, so we covered those peg laterals without having to cut anything. So we just glued to those peg laterals straight away after the braces came off. And that was the final result. So we went from this all the way to there. So that was with surgery, braces, and then resin bonding to the 1-2 and 2-2 afterwards to get that really nice cosmetic and natural result. So that's it from me, guys. If anything at all, I hope I've kind of opened your minds a little bit to what you can and can't do with braces, what you can and can't do with clear aligners, and yeah, I mean, thanks Visheka, thanks Catherine, thanks GUDSA for inviting me onto the show, I guess, the webinar program tonight. I'm just going to kind of open up to questions now. And I don't know if Visheka or Catherine, you guys have questions?
Yes, that was absolutely wonderful and very, very insightful. I think, like you said, clear aligners is something that we're not really taught. Our ortho program has really developed in the last couple of years, but this is something that a lot of us know is very common in our first couple of years of general dentistry. So I've learned a lot. I know Catherine has as well, who's sitting next to me right now. And I'm sure everyone here has really enjoyed this lecture. I've personally got a couple of questions. I think there is one in the chat, but I might ask one of my questions first. This is just about something you said earlier, Dr. Sam Koh, about the trim line. So you mentioned that the clear correct trim lines of the aligners are straight and not scalloped. And I just wanted you to explain that a bit more, because I know that, well, I've seen some Invisalign aligners which are scalloped. So I'm just wondering what the sign, like, is there a particular reason that Invisalign would use the scallop margins over the straight margins, considering there's this obviously of research that shows the straight line works better? But yeah, just something that you'd like.
Really simple answer for that. Invisalign is sold a lot to the public. So a lot of their early investment was to direct to public advertising. So they wanted patients to come into the dentist to ask for Invisalign. So it's kind of like Colgate. So when you walk into the dentist, you ask the dentist, I want Invisalign. They don't want Invisalign, they just want clear aligners. But it's just Invisalign sold everyone really early on and did a lot of brand marketing in terms of what clear aligners were. And their research and their experience was that scallop margins were much more aesthetic to look at. And they've just kind of kept with that because they're all about trying to make patients happy, not dentists or orthodontists happy, but patients happy. So that's the sole reason why they continue to do it, because they think it's much more aesthetic, and they think that patients and consumers and customers will then think that it looks much better. I have never had an issue with patients complaining about the trim line. Much more complaints about how many attachments that patients have. And because of the trim line with Invisalign, they do need, so you can see the study that they do feel as though that they actually need to add lots and lots of buttons. So you see a patient with Invisalign, right? They almost have buttons on every single tooth. And they sometimes have multiple buttons on the same tooth. And that's partly because of the fact that the scallop margin doesn't tend to actually retain to the tooth very well. But they also need to find a way to then kind of grab the tooth, push it a little bit better to kind of align those teeth a bit better. So yeah, that's the really straight answer to that.
Yeah, no, thank you for answering that. That makes a lot of sense. I do have another question again. So just about what you mentioned with clear aligners, that they need to be worn for 22 hours a day. How do you, I guess, deal with patients who would say prior to treatment that they will be compliant? However, throughout the treatment, you might find they're not so compliant. Have you had a case like this? And how do you manage their expectations knowing patient compliance is the issue?
Good question. Like, that's what I get asked all the time. And this is to do with everything too as well. So if you guys are asking the same about veneers and like crown, bridges, veneers, all sort of stuff, you need to understand that expectations need to always be set right at the start. So you should never take onus for something failing, unless obviously you screw up. But if patients are going through ortho treatment, clear aligners, they need to know and understand that it's their responsibility, and it's set out in the contracts as well that I write up and present to them. And I go over it in very, very stringent detail that they have to wear it, otherwise it won't work. And when you have a kid in the room too, the best thing to do is always to have the parent in the room and make sure that mum is sitting in the corner. So I'm not being sexist or anything, but it's usually mum that's much better than dad, because dad's a little bit more whatever. But mum in the corner when something's not going right. So if little Jimmy is not wearing his trays, mum knows that Jimmy hasn't been wearing the trays, right? Even if Jimmy came in and said, oh, I've been wearing them 22 hours a day, I've never taken them out. You kind of know mum's in the background, and you know what mum's going to say in the car ride home when you tell Jimmy that teeth aren't moving the way that they're supposed to, and question whether or not they've been wearing the retainer very well or the aligner very well. There are also some telltale signs throughout treatment as well, as to whether or not they're wearing their aligners. And one of the first things is, are they even coming to the clinic with their aligner trays in? So the amount of patients that actually come and see me and they're not wearing the trays at all, and then you ask them where their trays are, and then they go, oh, sorry, I just had a coffee, or oh, sorry, I just had a work meeting. They're the patients that you need to start worrying about. You also need to worry about the patients where the trays come back and they're super clean, because 2 weeks of wearing the same tray usually gets them pretty grotty. Like, they start having that little bit of that white, powdery, plaquey sort of look to them. And you always ask the patients to bring back all their old trays. So one of the tricks of the trade is with clear aligners, sometimes we kind of jump backwards and forwards. So if a tooth isn't moving, we might say go back 1 step or go back 2 steps, and then kind of go through the process again. So you always ask the patient to bring back all their old trays. And if they don't, then you kind of have a few alarm bells there and go, oh, what the heck's going on as well. All right. So they're telltale signs along the way, but you also want to kind of preempt it beforehand too. So if they have bad oral hygiene, if they have lots of holes, if they keep forgetting their appointments, they're rocking up late, they haven't taken their x-rays for you, like their OPG and their LATSEF, you kind of go ding, 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 like this may not work out. And again, this is not to be sexist, and I hope this doesn't offend anyone, but I usually won't do clear aligners on any teenage boys. Yeah, it's just one of the things that it is. Like, usually if I'm going to do clear aligners on teenagers, it's only going to be girls. I find that females are much more compliant. They have better oral hygiene, and they kind of understand the consequences of not wearing their aligners as much. Does that answer, Tasheka?
Yeah, that really does. Thank you so much. We've got a couple of other questions. So I think we had one earlier from David.
Yep. So how long would you expect the additions on the central incisors to last for? Great question, David. So this comes back to the whole principle of align, bleach, bond. And one of the principles is the fact that you want to take the teeth out of the occlusion that caused that trauma, caused that chip, caused that harm, caused that wear, right? So I would very, very easily love to actually tell patients that my resin edge bondings are going to last anywhere from 5 to 8 years, just like I do with all my resin veneers. Nothing like the 2 to 3 years that you get taught in uni, where they say, oh, your little small anterior fillings, you need to tell patients that they're going to get replaced every 2 to 3 years. It's different when you align teeth, because what's going to happen is you're moving the teeth out of a danger zone or an area where it's going to keep knocking on itself or keep knocking on the opposing tooth. So generally speaking, you want to get that canine guidance. You want to get those anteriors out of occlusion when, especially you're doing lateral excursions. You want to make sure that even when you procline those teeth, then what's happening is essentially that, you know, it's even contacts, or the anterior teeth or the anterior fillings are not in contact at all, even when they're trying to procline and slide their bottom jaw forward. So I hope that kind of answers your question, but roughly speaking, with any sort of resins, I give a rough time frame of lasting 5 to 8 years before we need to kind of modify them or adjust them. But I still do warn them that little chips can happen here or there. I've got a few direct messages as well, so I'm just going to say that now, ask that now. So thanks, Dr. Koh. Do you do clear aligners on children if they're compliant? It's a bit tricky. I know Invisalign sells a product called Invisalign Teen. Invisalign and some of the other brands also sell growth modification appliances. I do clear aligners on children. I do clear aligners on children that are growing, but generally not kids bare minimum under about 10, 11 if they're girls. Compliance is a big thing, right? Like, think about how compliant you are as a kid, right? Did you take your antibiotics properly? Did you take your Panadol properly? Did you eat your lunch, your school lunch that your mum packed, right? Like that sandwich that she packed, did you eat it because she told you to? Probably not. So to answer your question, unless the child was super mature, super diligent, you can tell those kids too. They're really a needle in a haystack. Like, you'll know when you come out when a kid is going to be compliant. Then yes, I can do clear aligners or even ortho on them. But yeah, they need to be compliant. I hope that answered your question. If it didn't, shoot me another direct message. Next direct message. Hi, Dr. Sam. How do you go from simply accepting a clin check to making adjustments you know will work in the patient's favor? So this is where mentoring comes really important. Like, you need someone to look over your clin checks for your first maybe 10, 20 cases so that you understand what you're looking at. So you need to understand what position you want that final tooth to look like. You want to understand what torque you need to add to that tooth. There's a difference between crown torque and root torque that you guys may not understand right now, right? You need to understand, how am I going to get the best aesthetic result in terms of the lip line, in terms of the smile, in terms of the buccal corridors, so that my clin check's going to relate then to something that looks pretty in the patient's mouth. So to answer your question very bluntly, at the start, unfortunately, you may need to kind of have a bit of trial and error and just do a few revisions along the way. So you just do what the technician says, and then at the end, order more trays to make things look better. Or at the start, if you want to have a really good plan in place, then get a good mentor. And sometimes the orthodontist is probably not the best mentor here, because you need a restorative orthodontist or a restorative orthodontic dentist to then be able to plan that restorative treatment with you. So then you can then figure out how you're going to plan that final treatment as well. All right. Tusheka, did you want to ask the public questions, like from Ben and stuff, or are you happy to just...
Yeah, sure. I'll get Catherine to read this one out. So we've got a big one from Ben.
So how do you plan for the resin bonding after the alignment in terms of how it will function in occlusion? Do you have to wait until the alignment is finished before you start planning it, or do you plan it before the alignment starts? So maybe by using the presumed end alignment result.
Okay, cool. Yeah, good question, Ben. As I mentioned before, you want to plan everything as much as you can from the start. The best way to do it is to do either digital smile design, or you at least get some PowerPoint little templates up and try to figure things out from there. Okay. It's not the final plan though. This is kind of like a preliminary or a draft plan that you're then going to revise once you get closer towards the end of your finish. So, for instance, that 1222 edition case, we kind of planned for the amount of space that I wanted there. I didn't plan for that much else. I planned for the fact that I wanted that 6 mils for the lateral incisors to be able to actually bond to. And I planned for where I wanted those lateral incisors to finish up within that 6 mil space. So I got really nice emergence profiles and contours. You then also want to plan, like I mentioned before, to that private message, that it's going to function in occlusion where it can function definitely in static occlusion, but especially if you're going to resin edge bond, right? So not really a veneer or anything, but resin edge bond. You want to make sure that when they protrude their bottom jaw or procline their bottom jaw, that you're putting not a lot of lateral stress on that palatal aspect of the edge bond. And if you are, it's evenly distributed across all those anterior teeth. So that way you can get the most out of your anterior composites. And lastly, a lot of the times, if you do resin edge bond, a lot of the times they've worn down those teeth because they have parafunction. So one of the things I'll do, instead of giving them retainers at the end, they'll get an occlusal splint at the end. Okay, so that is to protect their teeth with their parafunctional habits. Let me just see if I answered that whole question.
Just back on the parafunctional habits, how would you protect those patients' teeth if they were to be clenches during the day? Because obviously they wouldn't be wearing an occlusal splint during the day. So how would you go about managing patients if you aren't giving them retainers, or would you give them a retainer as well as an occlusal splint for overnight wear?
Yeah, so are you talking about patients in active treatment?
No, this is so for patients post orthodontic treatment, when you just mentioned how you'd give them clear.
Oh, okay, yep, sorry.
Yep.
Yeah. So they will get clear aligners as for retainers during the day, and then a splint at night and a lower Hawley. Okay. So that way it doesn't interfere with the occlusion. The only thing I'd say for a Hawley, and I said this on the course on the weekend, is when I make my Hawley retainers, I think Hawleys are a terrible retainer, because the metal wire, the labial bow that you have, only touches the buccal aspect of your teeth in one point, right? So if you think about it, that one point is not going to hold the tooth in its current state as well as the root in its current state. You need a flat surface area to actually touch the buccal surface of your teeth. So when I order my Hawley retainers, I get the lab to make a clear acrylic labial bow. So what that essentially means is actually a flat strip of clear plastic that runs across the buccal aspects of all the teeth. It's perfectly molded to all those teeth, so it actually even goes into proximal, and that will retain your teeth much better than a traditional Hawley will. So it's worth the extra $30 that it costs for that labial acrylic, and that's what I'll do. So you can either do one of two things. You either give them the clear aligner retainer, so Essex retainer during the day, then a lower Hawley and an upper splint at night, or vice versa, upper Hawley and a lower splint. Or you just get them to wear Hawley retainers top and bottom during the day and at night, if they have very, very mild parafunction and you're not going to give them a splint. And then obviously Botox if you want to.
Excellent, thank you. Are there any more questions to you? Because I've got another question here, Dr. Koh.
I've got one more to Sheka. So I've got a message. Can clear aligners move teeth that are crowned? Short answer, yes. Long answer, you need to know that the tooth is aligned properly. So a lot of the times we crown teeth, but we crown teeth when teeth are crooked. So the dimensions of the teeth and the alignment of that crown are wrong. They're made wrong purposely to make the tooth look straight, but the tooth is crooked. So one aspect that you need to understand is, especially like, let's say you had a massive premolar space that you then crowned, so it ended up looking like a bit of a small molar. When you then go to align those teeth, the issue there is you're going to have a tooth size discrepancy. So at some area of that occlusion, it is not going to be class 1. There is not going to be good interdigitation, or the crown is going to stick out like a sore thumb. Because once you align that tooth root properly, the crown is probably not going to be in the right buccolingual or mesiodistal space, and it's going to look like garbage. So yes, you can align teeth that are crowned, but you'll either need to accept the current look and the position of the crown, or the width, sorry, the dimensions of the crown, or tell the patient to remake it completely after orthodontic or clear aligner treatment. But clear aligners are better to move crown teeth than probably braces, because braces, you need to actually remove the glaze off your porcelain crown, which may render the crown useless or anesthetic or chip or crack, and you need to replace the crown for sure.
Thanks, Dr. Koh. We've got one other question. So what are the implications of ankylosis and retained deciduous teeth with orthodontic work / clear aligners? So probably a bit more of a complex answer.
Sorry, what was the question again, Thusheka? Sorry.
No, it's okay. I'll read it out. It's probably a bit more of a complex answer, this one. But what are the implications of ankylosis and retained deciduous teeth with orthodontic work / clear aligners?
If you have ankylosis, you have ankylosis. So it is essentially like having an implant in your mouth. And that's why I said when you first start out with your orthodontic journey, probably don't do anyone that's got an implant, because ankylosed teeth are exactly the same thing. They are just permanently screwed into your jawbone. This can work to your advantage. So if you are really proficient at orthodontics and clear aligners, then you might then use that implant as your skeletal anchorage. So your support, your pillar, your post, to then push every other tooth around, right? However, if you have an ankylosed tooth, if you have an ankylosed implant, it is not going to move ever, right? Unless you cut that jawbone up and physically move it in the jawbone, it is not going to move. So you need to understand that ankylosed teeth, you just need to accept their position, and whether or not you then have to crown lengthen, or whether or not you then have to crown over it or veneer over it afterwards, or even extract it, that is the severe implication of ankylosed tooth. You need to consider actually masking the ankylosis. And same goes for an implant too. So if the implant is the wrong spot, either remove that implant and start again, or mask the fact that it's in the wrong spot. Yeah. I have another direct message. So are we able to bond buttons or brackets onto Emax or zirconia crowns? Good question. You can definitely glue to Emax, because Emax is a what we call an etchable crown. Excuse me. So with Emax, you just have to understand that just like a PFM, you are going to disrupt the glaze. So you need to cut the glaze off. So polish back that smooth surface that you see, get to the rough ceramic, and then you can definitely glue to that with a silane primer, and then any bond system you want, your prime and bond active 2-step stuff that you guys flush around with at uni. The little disclaimer that I've got for zirconia, you can't bond to monolithic zirconia. So unless it is a new generation zirconia. So I hope I'm not confusing too many people, but the new generation zirconias are etchable zirconias. So they're the ones that you see out there called katanas. There's another brand that I can't think of at the top of my head right now, but they're actually a hybrid in between a true zirconia and an Emax, so a lithium disilicate crown. So they have a slightly etchable component, which you then can bond to. Similarly as well, if you have a PFZ crown, so a porcelain fused to zirconia crown, which is a layered zirconia crown, and I'm trying to use as many terms as possible because I'm not sure what terms you guys get taught in uni. If you have a layered zirconia crown and not a monolithic zirconia crown, you can bond to that very similarly to a PFM or Emax. You just have to remove the glaze, because your surface porcelain is not zirconia, it's actually feldspathic porcelain, a very weak porcelain, but a very good porcelain to bond to. But you need to warn the patient, if you're going to bond brackets or buttons to Emax, zirconia, PFMs, or anything like that, then they need to essentially tell the patient that the crown might need to be replaced. It might crack, it might break, or it might stain once you take the bracket off, because then you're not going to have the actual clear glaze over that, and then it's going to be rough. It'll develop stain over time, and it might start looking ugly. I'm not sure if this is one of my associates. It may be my associate or not, or someone with the same name. Probably my associate, because he loves watching my webinars because he's got nothing else to do at night. I don't know. You can always ask me at work instead. But what percentage of clear correct cases are non-extraction? I know it's most. Can you explain why extraction cases are becoming less common? In uni, most cases we planned for in exams were with extractions of like upper 4s and lower 5s. Simple answer to that. Orthodontics in the past used to be what we call four on the floor. So no matter what orthodontist you went to go see, an old school orthodontist would always take out 4 teeth, get you take your wisdom teeth out, straighten up your teeth. That was orthodontics, right? We now know better. We now know a lot about airway space. We now know about intermolar widths, so 1/6 to 2/6 widths, and the relation between tongue posture, sleep apnea, breathing disorders, all that sort of stuff. Again, most of what I'm telling you guys is the fact that if you use auxiliaries correct, if you plan a case properly, don't do Invisalign Go, expand out the arches, use what we call molar distalizers to distalize your molars backwards, you should be able to gain significant arch length and arch width and arch space to do most cases non-extraction. And the reason why we want to do non-extraction now is, why are we taking out wisdom teeth that have nothing wrong with them? Why are we taking out premolars that have nothing wrong with them? Just because we can't treatment plan the case properly, we're taking these teeth out because it's easier on us but worse for the patient. So that is the simple reason why a lot of cases are now becoming non-extraction. That's not to say I don't do extraction cases. I do a lot of extraction cases, but you start with the goal in mind to do as less trauma or less damage to the patient as possible and work backwards from there. Okay, so there are some cases we just need to compromise. The patient's finished growing. They don't want to go through extractions. They don't want to go through surgery. They don't want to go through molar distalization. They're happy to have a tooth out. Mum and dad want the tooth out. They have time frames to adhere to. So there are some reasons why we might take teeth out. Other reasons we might take teeth out is because they've got hypomin, they got big molar root canals, or they have big root canals and chipped composites. Yeah, so that's the main reason. What percentage of clear correct cases are non-extraction? Honestly, almost 90% of my cases with clear aligners are non-exo. And when they're exo, they're planned really well. So you plan the root torque and the root position and the root tipping movements very, very slowly. So then you get a really predictable outcome with everything. And even then, when you do the final OPG, you'll probably see that the roots are still kind of lagging behind a fraction. But you know, you can plan it pretty well these days that you can get a really, really nice result with extraction cases or non-extraction cases, both with ClearCorrect, Invisalign, and any other brand. I think that is all my direct messages. There you go.
Beautiful. Thank you so much, Dr. Sam Koh. We really, really enjoyed that lecture tonight. I think that's pretty much covered all the questions that I can see. Just a couple of thank yous coming through, and general consensus is everyone really loves having you on board. So thank you again for spending your evening with us. It's really great to hear the Melbourne practices are picking up after COVID. I know you guys had a really rough year last year, but I'm really happy to hear everything's picking up for you. And so glad you can make time for us as well, because especially after a long working day, to spend, an hour and a half, almost 2 hours chatting nonstop is probably really exhausting, but we really appreciate you back on board. And we are also going to be having Dr. Koh back again in semester 2. So if anyone has any topics of interest, please either contact myself or email academic@GUDSA.org. And we'll take that into consideration and let Dr. Koh know, or you can even direct message him, but he's a very busy man. The other thing is, Sam, I think you might need to get someone to manage your Instagram profile. Oh, sorry, I don't know if that cut out. I was just saying.
Sorry to check out my internet.
That's okay. I don't know if it's mine or yours, but I was just suggesting that you might need to get someone to manage your Instagram profile from now on.
Yeah, look, Instagram is fun. It gets yeah, no, I do. I probably need someone full time on my Instagram, just like some of the other clinics out there. But it is what it is. I'm busy enough. I'm happy enough. But yeah, I mean, so So the 40 people that are still here, I'm thinking maybe the next topic, to be honest, might be something to do with like onlays, if you guys want to hear about that, or we can talk about, do we do posterior composites last year? I can't remember.
We did. Yes, we did do posterior composites. I think onlays are great. And again, aesthetic dentistry related things. So I guess onlays and probably veneers might be a good topic to start. I don't know whether that could be combined or if that's something that you might separate. Probably a big topic to channel in one day. So perhaps even 2 lots of lectures. You know, we're more than happy to organize multiple times as long as that works with your schedule. But onlays for sure. We only get to really do them in sim labs in year 3. And then unfortunately, all of first half of year 4, we don't get to, or we're not really allowed to see patients for onlays until the 2nd semester. And it also depends on whether our patients are willing to, of course, pay for having onlays and crowns done. So the chance of us getting any onlay cases until we graduate is pretty low. So the more exposure we get now, the better, really.
I'll tell you, if we actually do onlay webinar, there's actually probably a pretty good chance I can probably try to score some freebies for everyone at GUDSA. Not just Optiv 1, but like maybe some other stuff to play with. But yeah, leave it with me. We'll have a chat and we'll figure. Everyone shoot through Sheka and Catherine and the academic committee a message about what topics you might want to do. But we might be able to get some freebies sent out to everyone to actually maybe even play with whilst we're talking. I'm not sure. I can throw something up.
Yeah, no, I do really like the sound of this. So we'll tee up something for that. We do have one question that's just snuck in regards to Invisalign and the steps for each new tray. What's the issue if a patient wears the next tray before the next date?
Yeah, cool. Good question. Again, people's biologies are different. And if unfortunately they wear their trays too early, what may happen is that the teeth may not have moved to the shape of those actual trays. So let's say they're wearing step 3. The teeth may not have moved properly into step 3's shape if they move on to step 4 too quickly. So unless you know how quickly the patient's teeth are moving, and you know that they can wear them only every 7 to 10 days, not 2 to 3 weeks, then try to keep them on that schedule so that you are confident that the teeth are going to move predictably into that shape.
Awesome, thank you. I think that's everything. But yeah, like I said, we'll contact you about organising another lecture. Onlays sounds like a really good topic, and I'll have a little suss around all the other year levels to see what else is of interest. But yeah, anything aesthetic, dentistry, veneers, onlays, that seems to be the go at the moment, and very popular with I guess the Instagram dentistry world. So it's something that we see constantly, but we also don't get enough experience with. So that would be absolutely fantastic. Thank you again for your time, and thanks to all the people that are still logged in, but that is it for tonight. So until next time, that's it from me. Thanks, guys.
Thanks, everybody. Thanks, GUDSA.